Good afternoon, and thank you so much for joining us here today. My name is Dr. Monica Burrell. I'm the Commissioner of the Massachusetts Department of Public Health and a proud alum of this school as well. I'm so pleased that you could be here to join us today. This live webcast is presented by the Association of State and Territorial Health Officials, or ASTO, and in association with the forum here at the Harvard T.H. Chan School of Public Health. Welcome to all of you both online and in person in the studio today. I want to introduce you to this unbelievable group of panelists we have with us here today. First, I'll start with Dr. Stephen Patrick, to my right. He is the Director of the Center for Child Health Policy and Assistant Professor of Pediatrics and Health Policy in the Division of Neonatology at Vanderbilt University School of Medicine. Welcome, Stephen. And directly to his right is Dr. Karen Remley. She is the CEO and Executive Vice President of the American Academy of Pediatrics and a former Virginia Commissioner of Health. Welcome. And joining us remotely, we have Dr. Michael Warren, who is the Deputy Commissioner for Population Health at the Tennessee Department of Health. Welcome, Michael. Towards the end of this event, we'll have some time for Q&A, both from the audience and online, for your comments and questions. So please be ready. As a reminder, you can email your questions to ASTO, A-S-T-H-O, webcast @asto.org. So I'm really excited when ASTO and the forum decided to take on this topic, because it's really one that we all need to think about together and put our minds together to make sure that the individuals who we're going to talk about today get the treatment and the hope in recovery that they need. So to frame the situation today and why we're here today, the CDC reported that in 2016, we had over 42,000 individuals die from the opioid epidemic. And we talk a lot about numbers, and a lot of us are really used to dealing with numbers, but just pause for a second and think about the sheer magnitude of this issue that we're dealing with, which has been a call to action to really so many of us. 42,000 human beings, many of them in their prime of their life, 25 to 44 age group, lost. And when we think about that loss and we talk about these numbers, behind each one of those individuals is a family, is a community, is a network of individuals, and is this great grief. Before I was here at the Department of Public Health, I am a primary care internist by training and worked in and around the Boston area for over 20 years, and tried to help a lot of individuals on their path to treatment and recovery from substance use disorder, and really saw firsthand how much of a struggle it can be and how much they really need our support in navigating this complex system we have, but then also really being able to see individuals who share this capacity to be treated and having hope and a future in recovery. So I want to frame for the Massachusetts picture. I'll just give you some numbers. If I could have my first slide, please. So if we look at this, and I know from my colleagues at ASTO that many states have a similar picture to the one we have here in Massachusetts. I show you this as way of example, that since the year 2000, when we measure our opioid-related overdose deaths, we see this really alarming, almost 500% increase. And if you look at the last few years from 2013, 2014 on, you see the sharp increase in those deaths. And really, we haven't seen this kind of a rate of increase from a single medical disease since the beginning of HIV. So this is really a call to action of all of us in health, in healthcare and public health, to really pay focused attention to this issue. The other thing I point out for you is you'll see the areas in red. We talk a lot in public health about data. We developed a predictive model that we could use so that we can produce more real-time data on the opioid epidemic, and that's our prediction model being used there. So now it's just a 3-month delay to see the information in Massachusetts, and it's showing us some really important things. For example, in the last few years, we know that one of the factors in this deadly increase in deaths is fentanyl. Fentanyl, as many people in the audience know, is 50 to 100 times more powerful than other opioids. And illicit fentanyl that's available now throughout Massachusetts in many states is really driving this increased death rate. And we know that because in this last report that you see in front of you, 83% of the cases of the opioid death where we had toxicology, 83% had fentanyl present. The other thing I want to point out to you is that if you look at the last year, you'll see that slight decline in the number of deaths. And just like other disease epidemics, we are watching it carefully. And as we put in our multiple interventions, which are done through a public health lens of prevention, messaging, intervention, treatment, and recovery, we might be beginning to see it work. You know, are we done? And should we go and have, you know, a cup of coffee together instead? Of course not. But what we're seeing is that it's possible that if we continue with these interventions, we continue with our efforts, we make sure we're getting the highest risk groups the treatment that they need, that we may begin to see more of a decline in this. Next slide, please. And, you know, the time is now. So our data that we've put together in Massachusetts shows us really strikingly that if you take all of the individuals who died, so this is a survival curve, those of us in health are used to seeing some of these, it's really striking that if you map people back from the time that they died to their first use of opioids, it's just 36 months. So as we think about how to get individuals around us mobilized to do this work, our legislative partners, our government partners, our agency partners, our academic partners, it's because the time is now. We don't have a lot of time. We must act now. Next slide, please. We did a data mapping project that is ongoing here in Massachusetts because data is part of our strategy to understand how to address this opioid epidemic. And what you can see here is one thing that I want to leave you with is the use of medication-assisted treatment. There are 3 FDA-approved medications for this, for opioid use disorder, and we're not using them enough. In many ways, it's as if a type 1 diabetic who needed insulin wasn't getting insulin when they presented for care. So what you see in front of you is the data in Massachusetts to prove that, related specifically to methadone and buprenorphine. So what you'll see in front of you is that when we tracked back in this database that we had, individuals who came in for a non-fatal overdose. So we say, okay, when someone comes in for a non-fatal overdose, that's a chance to intervene, to be able to say, let's take this individual at very high risk, one of the highest risk factors is a non-fatal overdose, and see what we can do. And we know, by the way, from decades for methadone and many years for buprenorphine, from peer-reviewed literature, that those medications work. But here's the Massachusetts data, which shows the same thing. If an individual presents with a non-fatal overdose, and they get started on methadone or buprenorphine, their risk of death, fatal overdose, goes down 50%. I mean, that's as good as any medical treatments those of us in medicine can say we have. So we know, people ask me all the time, what do we need to do? We need to get more people treated for this disease that they have. And I bring this up in particular today because this comes up, and I hope to ask my panelists about this. This comes up in a very challenging way for some people around moms and their babies and children. So I highlight that for you. Next slide, please. And talking about moms and their babies, we did some work here in Massachusetts where we looked at who the highest risk groups were. And I don't have time to review all of those with you, but I point out for you, as relevant to today's conversation, pregnant and postpartum risk. So we looked at the risk of opioid overdose by different groups. And when we looked at moms, here's what we found. So if you look at that first blue line, the rate of 2.1, that's 1 year before delivery, so prior to conception. So you could say that's the woman's baseline risk. And maybe you expect it, maybe you don't, but as they go through pregnancy in the 2nd and 3rd trimester, that risk comes down substantially of opioid overdose. But then, after the delivery, it starts to come up again. And what was most profound for us here when we looked at this data was that the risk was highest in the 6 months to 12 months after delivery. It's not by accident that sometimes that's a period after which many of the services that we're used to providing aren't provided anymore for new moms and their babies. So that fact alone has really helped us in our programming and policies as we think about how to support moms with opioid use disorder. So I share those few facts with you. I'll make sure that everybody here has access. This is just the tip of the iceberg of some of the information we found about who's at highest risk, who's dying, where, how, what some of the factors are that contribute to higher risk. So I'll make sure you all have that as a resource. I'd now like to transition over to our panelists to get their thoughts as I, put in front of you some of the challenges that we're seeing and the scope of this problem from a Massachusetts point of view. Let's talk about those challenges with our panelists. So Stephen, if you could start.
Happy to. Well, I'm also a graduate of Harvard School of Public Health, and it's a great honor to be here with you all, particularly with these panelists.
Can you make a poster of us?
Yeah, that's right. The opioid epidemic has garnered substantial attention from the public, and that's for good reason. Today we still use 3 times as many opioid pain relievers as we did in 1999, and we use 4 times as many as Europe. As Dr. Burrell noted, we're seeing increasing complexity now with rises in heroin and fentanyl-related overdose deaths. And the time that we sit here today, about 7 people will die from an overdose death throughout the United States. So the stakes are high. My introduction to the opioid epidemic came through the eyes of my patients who are newborns. Recently, I was caring for a sick infant in the neonatal intensive care unit. The infant had trouble feeding, was jittery, had rapid weight loss, up to about 10% after 2 days of life. Something was clearly wrong with the infant. The infant was exhibiting classic signs of neonatal abstinence syndrome, which is a postnatal opioid withdrawal syndrome that some infants experience. But like many conditions, neonatal abstinence syndrome can present pretty vaguely. Over the next few days, the infant became increasingly irritable, continued to have difficulty feeding, had increased muscle tone and tremors. And we suspected that the infant was having opioid withdrawal, but his mom denied any use of substances or opioids. After about a week in the hospital, the umbilical cord testing came back positive for an opioid. And as I walked into the room to talk to his mother, I could sense her guilt and her anxiety. And she cried as I talked to her about the drug test. She wondered aloud if she would lose custody of her infant. And she was afraid of my response and the response particularly of child welfare. Like too many women I see, she was dependent on an opioid from an accident well before she became pregnant. She was unable to get treatment for opioid use disorder, and she was too scared and too ashamed to ask. This combination is potentially dangerous. As a practicing neonatologist, I've seen firsthand that the destruction that opioids can have on families. Neonatologists like me are trained to take care of very small and very sick newborns with complex birth defects. But increasingly over the last few years, we've seen a different population of infants, and these are infants having drug withdrawal. This once rare diagnosis is becoming increasingly common. From some of our team's work, we know that over the last 15 years or so, there's been a near 7-fold increase in the diagnosis of neonatal abstinence syndrome. In 2014, more than 30,000 infants were diagnosed with the syndrome. And to put that in some context, that same year, that's about the same amount of births total in West Virginia and Alaska combined. And it equates to about 1 infant born on average in the United States every 15 minutes on average. As with many diagnoses in the neonatal intensive care unit, it really represents a complex set of events that begins well before pregnancy, and it also has implications well beyond birth. Looking at this diagnosis in isolation really misses an opportunity to improve outcomes for families. First, let's begin with pregnant women. Pregnant women with opioid use disorder have difficulty accessing the most effective treatments for opioid use disorder, and they're not receiving highly effective therapies like buprenorphine and methadone. As Dr. Burrell mentioned, we know that this decreases the risk of relapse and overdose death. There's also benefits for the infant. It makes it more likely that the infant will be delivered at term and have higher birth weights. In a recent study by our group, we looked at specifically at treatment providers in Appalachia, in 4 Appalachian states that have been disproportionately affected by the opioid epidemic. We found that in those communities, only about half of providers took any insurance at all. And for outpatient providers, only about half were willing to accept pregnant women. Being pregnant and having insurance in some cases is a barrier to getting access to treatment. Infants are also too often seeing variable care. In an audit that was done of around 200 hospitals throughout the United States, less than half of hospitals had a policy in place, a protocol in place to standardize the diagnosis of neonatal abstinence syndrome, and only about half had a policy on whether or not a mom could breastfeed their substance-exposed infant. And yet we know that doing the same thing every time improves outcomes pretty substantially. In some studies, it decreases the length of stay in the hospital by about half. And next, in large part due to the opioid epidemic, our child welfare system is stretched, and it's exposing cracks in a system that's already overburdened and underfunded. In 2015 alone, the number of children entering the foster care system increased to nearly 270,000, and that's up from 250,000 in 2012. In 2015, infants represented about 1/5 of all removals from their families to foster care, totaling around 50,000. Parental substance use was a factor in foster care placement in nearly 1/3 of all cases. The deeper you dig, the more you understand that this is a complex problem, and it requires a thoughtful, comprehensive investment that includes the needs of pregnant women, infants, and families. I look forward to discussing these issues more deeply throughout the afternoon, and it's a pleasure to be here with you all.
Thank you, Dr. Patrick. That's really important information you're sharing, and thank you for the work that you do. Dr. Remley, could you talk a little bit about not only the child and the mother, but the family and the implications that this has for them?
Sure, and I think for all of us to think about, this is a multi-generational issue. So whether it's the baby, the mother, the father, who we don't talk enough about, the grandparents, everyone is involved, and the other children in the home. So it really impacts the entire community. It's a family effort. And I want to show my first slide because I think it's fascinating. If we think about the 42,000 people that died last year, who are these people? These are adolescents. Is there anybody in the room who loved their adolescence? Very few of us raise our hands and say it was the best time of my life. What goes on during adolescence? You're trying to identify who you are. You're trying to establish relationships with others outside of your home. You're engaged in risk-taking behavior. Your brain is growing incredibly fast. And we have some science that shows if you start to engage in addictive behavior in adolescence, it follows you throughout. So whether it be those 42,000 people that die, many of them started in adolescence, or whether it be those mothers who have a baby who has neonatal abstinence syndrome, all of this starts in this very, very difficult time. I think we talk a lot about, we know that there are some children that may get an opioid because they've had an injury, a sports injury. They may go to an emergency department because they were playing competitive soccer and had a significant injury and get an opioid and have an unusual reaction and then become addicted. We also know that there are some children who get it from some other child who says, hey, you're going to feel really good if you take this medication, and they start taking it and become very quickly addicted. There are a large number of adolescents and children who engage in risk-taking behavior with alcohol, with cigarettes, with e-cigarettes, with marijuana. And this can be another part of that activity. And some engage in risk-taking activity driving cars and using firearms. So it's that time of life where it's a real hard time for all of us as we go through to learn how to grow up and what to do. So I think that's important for us to remember. And I'll show my next slide. And I think what's really important here that hit me is we talked about those 42,000 people that died last year. There's 153,000 adolescents between 12 and 17 in our country that have had a diagnosis where somebody actually coded the diagnosis of opioid use disorder. So you know that that's probably 3 or 4 times more. Those are 12 to 17. So these are children. They haven't graduated from high school yet, and a healthcare provider somewhere has already identified them as being an opioid use disorder. So if you think of was it 36 months, I think you said, from the time you're diagnosed until the high risk of death, we're talking children that are going to be at high risk of death. And so that, to me, is very scary. The other part of that is, of that 153,000 that Sam's identified, only 1 in 4 get pharmacotherapy. So people are afraid to treat kids less than 18. It's hard for mothers to get access because they've got a baby in utero and people don't want to go there. People also don't want to treat an adolescent. So it's a real gap as we look at what we want to do to really attack this epidemic, is if we take care of everybody who's 18 to 35, but we don't go further up and say, how do we help those adolescents? We're going to continue to see the same numbers. So I'll go to the next slide and say that it's not only about, we said it's not only about adolescents, but it's about the whole family. And this is, of course, what all of us want, right? A beautiful baby, both parents, loving. Hopefully they get to go visit grandparents frequently, and the grandparents think it's the best baby in the world. But as you go through this, there are many things that impact a child's outcome. And we'll show the next slide. And this is one of my favorite slides in terms of adverse childhood events, because it really is about what are the things that nurture the tree, that cause problems, and we know that children that have 4 or more adverse childhood events or experiences are much more likely to have an addiction. But if you look here, community disruption, discrimination, poverty, lack of opportunity, poor housing, violence, and then you look those are those adverse community environments. If you're in that community, what happens to you is you grow into that tree. You may be more likely to have maternal depression, substance abuse, domestic violence, physical and emotional neglect, divorce, mental illness, incarceration. And what we don't know right now is if I have a parent who is addicted to opioid abuse and doesn't have those other components, is that still a significant adverse childhood experience? I'd make the case that it is. And I think because we're now seeing an epidemic that goes across all socioeconomic statuses, we need to really think about that and look at that. And then my last slide, we talked about the impact of ACEs. This is the risk of illegal drug use. So if you're a person who is in a community that has adverse experiences and your home has adverse experiences, if you look at the end there, you're so much more likely to engage in this behavior. And I think for us, it's thinking about when you're that child, when you're the child who was either taken care of by Dr. Patrick in the NICU, or the older brother or sister. What environment are they in? How do we help as a community those children? What are the early childhood brain development activities we can take part in? So whether it's reach out and read and making sure that you're really encouraging talking and development, working with parents so that the child stays with the parent and that whole entire nuclear family, whatever it is composed of, has the support and the love to be able to encourage brain development in that child. We work very closely with Head Start because many of these children with an early aggressive start in Head Start can really catch up on their language and they can catch up on their development. And it's an important way to be able to be, as we look at that, if we went back to that picture of the tree, those community issues. How do we support in public health the community, but then also do we help leverage and give the family the opportunity to support the things that are above? So thank you.
Thank you, Dr. Emily. It's really important that as we're so focused on, the neonatal abstinence syndrome or the mom, that there's a whole family and a dynamic. And I really appreciated your focus on the generational aspect because that's really what we're trying to prevent with our prevention models in public health. Dr. Warren, if you could speak to the group a little bit about the role of the state as we address these issues.
Sure, and thank you again for the invitation to be a part of this. Really excited to be on the panel with friend and colleague Dr. Patrick, and as an AAPM member to be on the panel with Dr. Rimley. This issue, as you've heard, can present a major challenge to the population, and opioid use may rise to the attention of public health through a number of ways. Perhaps an increasing number of opioid overdose deaths, as you've heard about. Perhaps even things like an increase in certain infectious diseases that are linked to substance use disorder. And as you've also been made aware of today, an increasing incidence of neonatal abstinence syndrome, or NAS. That's the one that I'm going to spend most of my time talking about and hope to dive in further later today. We gather information on NAS from a variety of data sources, and in public health, we may rely on things like hospital discharge data. Some states may gather data through a birth defects registry or surveillance program or through some sort of active surveillance mechanism. When we first started looking at this in Tennessee back in 2012, we were trying to get a handle on the scope of this problem. We were hearing from community providers, particularly those in East and Northeast Tennessee, which in our state are the areas hit hardest by this epidemic at that time, that their hospitals were literally bursting at the seams. They were having to add additional beds in their newborn nurseries and their neonatal intensive care units. And so they reached out logically to the state health department to find out what we knew about this, what's going on. And so we turned to the data that we had at the time, and those were hospital discharge data. And what we found was that there was a substantial lag that varies from state to state, but sometimes anywhere from 9 to 12, maybe even as far as 18 months behind, which you're in the middle of an epidemic trying to understand where you are, trying to look at data that are a year and a half old is not particularly helpful. And so our commissioner decided to add neonatal abstinence syndrome to our list of reportable diseases and events. Every state has one of these lists in their public health department. Historically, these have been infectious diseases that required some sort of contact tracing or quarantine. After 9/11, some bioterror agents were added. But it is unusual to see non-communicable diseases like NAS added. But we were able to add that to the list And one of the products of that, and I'll show my first slide, has been the weekly surveillance report that we are able to publish. So we use the CDC calendar, and so our weeks run from Sunday through Saturday. And every Monday morning, we publish some of the most real-time data in Tennessee state government, and that's our count of neonatal abstinence syndrome births. What you see on that slide is information on the incidence, so our cumulative incidence throughout the year to date, as well as a comparison of prior years since we started surveillance in 2013. You'll also see in the lower left-hand corner of that graphic is the geographic distribution across the state. So we know that the incidence varies across the state, and we're able to follow that. And then perhaps most importantly in the lower right-hand corner of that slide is the exposure source. This has been very helpful at trying to better understand what were the circumstances that led to this baby developing withdrawal. And importantly, as we'll get into later, how do we think about preventing those exposures and where do we best target our efforts? Now, lots of folks are interested in this issue, many stakeholders coming to the table, and public health has a very unique role. If you look at the next slide, we can be reminded of those essential functions of public health. And those are assessment, assurance, and policy development. That's different, for example, from our colleagues who are healthcare providers. Public health really has a unique role in addressing a variety of problems, including this one. One of our key roles is convening, and so if you think about that notion of mobilizing partnerships, there are many folks who play a role in this, and as you heard from both Dr. Patrick and Dr. Rimley, really this is broader than any one particular stakeholder. If you look at the next slide, I've just illustrated a number of the agencies, state agencies here in Tennessee that have been involved with this epidemic, and particularly if we think about the child and family serving agencies, not only public health, but child welfare, our state Medicaid program, our mental health agency that pays for treatment. Some of these families are involved with our corrections agency or may come into contact with our Department of Safety. And so it really takes a variety of folks coming together. As those kids get older, they're going to interact with the education system and even before that, early intervention. So all of those folks need to come together around the table to address these challenging problems. We will dive into this a bit later, but just to give you a broad idea, there are a variety of roles that public health can play and opportunities that we can support in addressing neonatal abstinence syndrome. In many states, the Public Health Agency regulates providers and prescribers, and so as we think about working with prescription drug monitoring programs and appropriate pain management, there's a role for public health there. We gather a lot of data. We can look at incidents of conditions like neonatal abstinence syndrome, but also some of the other consequences of the opioid use epidemic, whether those are fatal or non-fatal overdoses or infectious diseases that might be related to drug use. We can also do work to support important infrastructure, things like supporting perinatal quality collaboratives. In our state, tremendous work has been done by those perinatal partners to look at how do we improve the care for that maternal-infant dyad and how do we get that family off to their most optimal start. We can think about once that baby is discharged from the hospital, how does public health provide community-based services that support those families? And you heard Dr. Rimley in particular talk about adverse childhood experiences. What opportunities do we have to mitigate those risks through services like home visiting? And then finally, and this is I think probably one of the most important roles of public health, we can carry the flag for primary prevention, and that's preventing disease before it ever happens. In the case of this particular epidemic, that might look like engaging providers about their prescribing practices so we reduce the opioid supply in the communities. We might do things like drug take-back events, also reducing that opioid supply. And we might think about encouraging the prevention of unintended pregnancy among women with substance use disorder. So a number of roles that public health can play. I look forward to talking about that a bit more and then answering questions that you might have.
Thank you, Dr. Warren. It's really impressive what you've done, especially with that up-to-date data. It's really impressive. So the panelists have given us a lot to think about. And you know, each one of us spoke about this issue that I've been spending a lot of time thinking about recently, which is this is a medical disease and there is treatment for it. And as we think about that, here in Massachusetts, we've tried to help increase awareness around that. We have a new website called the Journey Project, which is really geared towards moms, both pregnant and postpartum, to understand what the resources are. At our Bureau of Substance Addiction Services, we have a pregnant women's access line, so they can specifically reach in and get information on that. But as everybody's touched on, there's still barriers. And I wonder, Dr. Patrick, if you could talk a little bit about those barriers and just some of your thoughts on that.
Sure. I think the biggest barrier is stigma. There's stigma around this issue overall, but I don't think there's any population in terms of substance use that is more stigmatized than pregnant women. And that's a barrier in itself in getting treatment. We do know that there are structural barriers. Oftentimes I find clinically that we have, in many cases, addiction providers that are not comfortable caring for pregnant women and obstetricians that are not comfortable dealing with addiction. And so there are immense needs. And the other part of this is that disproportionately we know that this is increased in rural communities. And those are communities that oftentimes have difficulty with access to treatment and not a lot of treatment providers. And I do think that we do have this other issue too, and in terms of how people are able to get access to services. And in many cases, there's cash pay. I was contacted in the community about 6 months ago about a pregnant woman, a postpartum woman that was trying to get access to opioid agonist therapy. She had access to it during her pregnancy, but was paying cash. What's weird about that is that clearly someone paid for her pregnancy and her delivery. What we find is that in many cases Medicaid isn't accepted, or there are other barriers that are there, and we really have to begin to step back and understand what are those structural barriers. Are they, what are the interventions that we've done to prioritize pregnant women into treatment? Are they working? How can we accelerate them? If I walked around my neonatal intensive care unit, as you pointed out earlier, and said, hey, I've got a medication that's going to increase your chance of survival by 50%, everyone would be, yes, bring it on. Yeah. And yet still, we are finding ourselves with pregnant women who are unable to get these treatments, and it's a big issue, and I think it's something that we have not even begun to scratch the surface on.
Dr. Remley, you also work a lot with families. What's your sense of the access to care issue?
I've heard the exact same stories that Dr. Patrick described, and part of this, we work as an association with ACOG, the American College of Obstetrics and Gynecology, to really think about how do we go all the way back, just like we're trying to go back and prevent, how do we get back to training programs and make sure that all OBGYNs are trained and comfortable in asking the screening questions, in removing the stigma, in knowing how to either treat or find treatment in your community, because it has become important enough, and there's nothing more frustrating for our OBGYN peers to want to refer a pregnant woman and get them the help they need, and there's no one to refer them to, and they also don't have the skill sets. So we're partnering on that. We're also thinking about, as we look at the whole family, when Dr. Patrick hands that baby off to the pediatrician in the community, what do they need to know? How do they work with the family? How do they make sure that they get the social services in a non-stigmatic way to support that mother, that baby? As you pointed out, I think it was 6 months, you said 6 to 12 months is when they're the most likely to relapse. Anybody here who's had a baby knows that 6 to 12 months can be, well, those first couple of weeks can be really, really hard, but 6 to 12 months, and think about, then they become terrible twos. There's all kinds of activities there that are very important for them to have that support. So I think somebody mentioned home visitation nurses, very important part of how you support the family. Making sure that as a clinician, you understand what the definition of family is for that family. Because family may be my best friend, or it may be my great aunt, or it may be my grandmother, or it may be somebody at church who cares about me that I can bring in. And so I think for a lot of clinicians who take on a lot of this care, it's really being thinking about what are the questions I need to ask and how do I incorporate that into my practice in a non-stigmatic way that will help this family get the support they need.
It's interesting. Well, it's interesting. I think we have the financial capacity already in the system. We are spending around $500 million a year in caring for infants in hospitals, caring for this problem. If we're able to shift that to prevention, expansion, treatment, then we would save dollars. And you talk about when going home. I mean, this. What I often feel like when I send an infant home, you can imagine families have social stressors already. They are eligible for early intervention services. Mom has addiction treatment, her OB care, the baby has a pediatrician, maybe child welfare involvement, and it's completely uncoordinated. And that is a stressor within itself. I think oftentimes we set families up for failure instead of success. And we know that infants with neonatal abstinence syndrome are about 2 times as likely to be readmitted within the first 30 days of life compared to uncomplicated term infants. We can do a better job.
You know, that's a great point you raised, and I'm particularly proud of a program where we've launched through a grant here in Massachusetts called Moms Do Care, and it's really gets at these concepts that both of you are talking about, which is using peers and peers, moms who are in recovery, to really be navigators, coordinators, and assist the women along. And they really also, to me, get at this issue of the stigma that the women talk about. I brought just a couple of quotes because they were so profound to me of some of the things that they say, if you don't mind me sharing a few with you. So this is from the women in the program. The Moms Do Care program is specifically geared towards my needs as a pregnant woman with opioid use disorder. I'm usually looked down on for being on methadone. Moms Do Care staff are helping people learn that we have a disease and to decrease stigma. The peer mom has been through what I'm going through. I could trust her and I could talk to her. The Moms Do Care project staff help me out big time. I never see the things in myself that they do. They believed in me. And you know, as we're talking about like how to coordinate the care and how to help folks and what the cost of different things are, you know, simply having someone who's had your experience, who validates it and shows you that love and respect has been so profound. And the vast majority of the women that we have in this program are continuing on MAT and really continuing their treatment. Dr. Warren, did you want to add anything on this topic? I know you've thought about it a lot as well.
I do appreciate the opportunity. You know, I was thinking as you were talking, prior to joining public health, I worked in academic pediatrics, and one of the things that we used to teach our residents was, you know, families come with a variety of needs, and they don't wake up and say, today's my Medicaid day, or today's my WIC day, or today's my home visiting day. They have all those needs going on at once, and so we like to think about this broad array of services that are available. And yet we're not always organized in the most optimal way to serve families and meet them where they are. And so as you were describing your program in Massachusetts, it made me think about a pilot program we've initiated here in Tennessee through our governor's children's cabinet that's called Single Team, Single Plan of Care approach. And this started through our child welfare agency. And when families interact with that system, particularly around substance use disorder, the agencies come to them. And so you might have public health, you might have early intervention, you might have community supports like housing around the table to help families deal with this challenge. We know that this is not a monolithic problem. This has multiple facets, and if we think about families getting back on a road to stability and recovery, it really does take that proverbial village. It takes all of those folks coming together to wrap around and support them. And so I think thinking differently about those care models is incredibly important.
Thank you. And Dr. Warren and Dr. Remley, you both mentioned more education for the clinicians, which I think is important because when we think about, as physicians, the education we get on, say, cardiac disease versus what, at least when I went to medical school, I received on addiction, it depended on who you were exposed to from an attending point of view, but it wasn't part of the set curriculum. And in Massachusetts, we've adopted core competencies for the 4 medical schools here that they voluntarily now have adopted. And so all medical students get a certain standard. And that's resonating through the residency programs too, but I really like your idea about, you know, how do you think about the OBGYN and how they'll deal, and the pediatricians with these new things that many people weren't trained on, which Dr. Warren hit on as well.
And I think for the clinical world, you know, we used to talk about delivering care at the bedside. We know with children, what we do at the bedside is, you know, just the tip of the iceberg. It's what happens every day at home that really impacts their overall health and well-being. And it's our job to help them navigate, to help them work through the system. And so pediatricians are really being trained now to think about all of the social determinants of health, to identify in the community where are the resources you need, and how do I ask you in a motivational, interviewing, positive way questions about your home, your children, their surroundings, so that I can give you that support that you need without making you feel like you're being stigmatized in some way or looked at differently than the next family that comes in the door.
That's terrific. Yeah, great point. Speaking about clinical standards, Dr. Patrick, you spoke about the great specialized care that a baby needs with neonatal abstinence syndrome. Can you talk a little bit about that variability and some of the work that you've done around that?
We do see remarkable variability, but one of the things that we've begun to do is to de-escalate the care that we're providing. The current model, the traditional model of caring for an infant that has drug withdrawal, is to separate that infant from their mother and care for them in a neonatal intensive care unit, which can be loud and chaotic with ventilators. One of the ways that we've changed care locally is first, of course, standardizing our approach to it, but keeping infants out of the neonatal intensive care unit unless they have a medical reason aside from drug withdrawal that they need to be there. So we launched a program in September of this last year. We've had almost 100 infants that have been opioid exposed that have been born at Vanderbilt since then. We've been able to keep moms and babies together. Traditionally, babies that have drug withdrawal are treated with an opioid like morphine or methadone. We only treat around 17% right now. That's a pretty specific number, around 17%, but 17% of our infants that are receiving morphine. Around half of moms are breastfeeding that are eligible to breastfeed as well. And we've been fortunate to have some funding to have a lactation consultant, a child life specialist to help support that program. You know, one of the things that we think about, I think we have this concern that these infants are terribly sick, and they just aren't compared to. I was talking earlier to somebody, when I was on call Sunday night, the infants I was worried about on call were not infants having drug withdrawal. They were ones that had, a bowel perforation or terrible pneumonia, not these infants. Many of these infants, I believe, can be cared for in their local communities if we're able to equip, particularly rural hospitals, to do that and support them through that. We know that a good chunk of infants are transferred from rural hospitals to urban teaching hospitals. And I don't know that that's always necessary, and it may be a way to keep families intact together, but we do have to begin to standardize and provide those tools for community and rural hospitals to do that.
That's great, and I think we also here in Massachusetts have seen that when we standardize the care and use some of these non-pharmacological, family-centered approaches, it's really having powerful effects when people are able to stay in their communities. And one of the things that my fellow state officials can do is we've sent out several clinical advisories around the standards and links to resources. So again, as clinicians, we're aware there's a lot out there, and there are ways. A lot of people have thought about this already. So we've tried to provide those resources so at individual hospital systems, they can also understand this better.
I'll just say quickly that support of perinatal networks, like in Massachusetts and like in Tennessee, that have really galvanized basically volunteer efforts to standardize care for infants. And we do know that state perinatal collaboratives, they reduce things like line infection rates, and for neonatal abstinence syndrome, they also reduce length of stay and begin to standardize care. So it's really important.
Thank you.
Dr. Burrell, one thing I think that's important to remember, as a pediatrician, I'm fortunate to have colleagues who can provide tremendous care for our patients once they're sick. But I would be remiss if I didn't sort of wave the public health flag and say our ultimate goal is prevention, and in particular primary prevention. And when we talk about NAS, that means preventing that withdrawal from ever occurring in the first place. And so I think there's some great opportunities for us to think about how we move upstream and prevent NAS from ever occurring in the first place. And there are really two primary strategies. One is to prevent substance use or prevent substance use disorder from occurring among women of childbearing age. And so if we think about policy mechanisms like prescription drug monitoring programs, prescribing limits, provider education, those kinds of things, there are opportunities there. There's also the opportunity to prevent unintended pregnancy. And as we think about that, how do we approach women of childbearing age, whether they are having substance use disorder or not? If we think about promoting infant health, we ought to always be thinking about a key question. Do you intend to become pregnant in the next year? And if the answer is yes, how do I help support you to have the healthiest pregnancy possible? If the answer is no, what are you doing that is going to prevent that unintended pregnancy? Now, that is an area where we have to be really thoughtful and considerate. We always want to make sure that we are absolutely non-coercive and that we're using client-centered models. And so while we may individually have thoughts about what are the most effective methods of contraception, it's really about that particular patient who's in front of us and what is her desire if she chooses to prevent an unintended pregnancy. What method works for her and her partner the best? but really always thinking about upstream. Once we've got disease, whether that's opioid use disorder or NAS, we want to think about secondary and tertiary prevention. So in the case of opioid use disorder, how do we screen for that? How do we connect folks to treatment early on? In babies with NAS, how do we identify that and treat that? And avoid potential complications. But ideally, in the public health space, we want to think upstream.
Absolutely, Dr. Warren. Thanks for mentioning that. And I'm sure the other panelists have comments about prevention, which is so
One
important.
thing I'd add to that is it takes two to make a baby most of the time. So the dad, the father of that baby during the pregnancy is very important, because even if the mother is interested in using medications, if the father is not, then you're setting up, again, thinking about outside of the clinic.
point, yeah.
When you're in the home, what do you do? What's that relationship between the father of the baby and the mother of the baby, and how do we make sure that we're supporting both of them?
That's a great point.
Because if not, you put that mother and baby back into an environment that really is going to set them up for failure. And I do feel like sometimes I can say this because I have two daughters, but I feel like the boys are getting left out in some parts of the conversation. And especially, we'll go back to adolescents, they're the biggest risk takers. And we do have some research to say they're the ones that encourage the young women to also engage in that risky behavior. So as we look back in those middle school, high school years, we need to always make sure we're looking at everybody, not just those people who have ovaries.
Can we encourage? Can we encourage the boys to stay away from my girls?
Yes. You've got a daughter turning 13 on Sunday.
On Sunday.
Oh, wow.
Yeah. Hi, hello. The other thing that is worth talking about is the role of Medicaid. We know that about 80% of infants that have drug withdrawal are covered by Medicaid. In 2014, about 1%. Nationally, about a little more than 1% of Medicaid births had neonatal abstinence syndrome, but nearly 7% of Medicaid expenditures on birth were to neonatal abstinence syndrome. And some of the ways that Medicaid could play a role at the state level, one is something that Dr. Warren mentioned earlier, which is decreasing. There is currently in many states a disincentive to place a long-acting reversible contraception at the time of delivery, and that has to do with bundled care. States like Tennessee, South Carolina, other states have begun to unbundle that care so that LARCs can be placed at the time of delivery. And I think many of the other issues we've discussed in terms of care coordination, Medicaid really has a central role in coordinating the care for the infant post-discharge, upstream and understanding and improving access to care for pregnant women as well.
That's a great point. Thank you. Dr. Remley, you started to touch on the prevention issues around adolescence. Can you talk a little bit around that?
We actually have a policy called ESPERT, which is to screen, a brief intervention, and then recommend treatment if possible, where we objectively talk to every adolescent as they move into middle school age about sexual behavior, risk-taking behaviors with alcohol and drugs, depression, risk-taking behavior with cars or firearms, and to be able to have that conversation in a motivational interviewing style with that young adolescent. And then if they have, you can imagine if you're kind of keeping score, if they have major problems, to get them into the appropriate treatment, but have them also feel comfortable talking with you about what's going on. I think, we could have the same conversation as you look at what's happening in middle schools and high schools around our country, where young adolescents and children don't feel they have movability safe adults to go to.
Sure.
If you're bullied, that's a risky behavior for use of substance abuse. And the movability of our families and the lack of connections. Children have less people who they feel safe going to when they have problems. So as we look at this epidemic, I think we need to look at our society and how we're supporting our adolescents into young adulthood, to think about what are the environments that will put them in a place where they'll be less likely to engage in significant risky behaviors. We all broke some rules somewhere along the line.
Not me.
Not you? Okay. Should we call your mom? But to be able to have them have the support they need, and if they do engage in risky behavior, what we see a lot of, and we have a number of pediatric addiction specialists around the country, the stigma of telling your parents,
Right.
I made a big mistake and now I'm an addict, is so great that they will be more likely to end up committing suicide or continuing to use because they're so afraid of the stigma of saying, I have failed you as a child. So that's a lot of things we need to be working on.
You know, that's a great point you raised, because we keep talking as, clinicians, as public health leaders, as parents. I got this tip, which will help you, because my daughter's almost 14, where somebody said, for your kids, make sure that outside of you, no matter how wonderful the relationship is, that they have a trusting adult that they can name, that they would go to. So it's such a concrete step for people to take, and relatively easy to do. So it's great that you raised that. I'm glad you mentioned ESPER too, because our Governor Baker, in his last opioid bill, which became law, put in a requirement to screen at schools, both in middle school and high school. And initially, understandably, our colleagues in the school systems were nervous about what they would find. Through the Department of Public Health, we've done a lot of training and assistance in how to respond. And the pilot schools that are trying it, it'll go into full effect in September, are finding that, just like you would imagine, most kids are okay. Right? But this allows them to really target in a precision public health way on the kids who could use the interventions that they maybe weren't focusing on, and then allow them to then look at what resources are available in the community. So I'm really appreciative that you brought that up.
And I think, we just this week heard of 2 very sad, very public suicides.
Of course.
Children that are potentially in that list I showed you of opioid use disorder are much, much more likely to take their own life.
Absolutely.
And so any supports we can provide to them as they're going through that difficult time is really important.
Right, absolutely. Important point. Well, I can talk to this group of fantastic panelists all evening, but being selfless, I'd like to now give this opportunity to our crowd. And first, I'm really thrilled here today to have a special guest, Dr. Rahul Gupta, who's my counterpart in West Virginia. He's the state health officer there. I'd like to start with you if you want to make any comments or talk about the wonderful work you're doing as well on this topic.
Sure. Thank you, Dr. Burrell, and thank you for the panelists. And I think acknowledging this panel is very important because of the significance of the work that goes into this. So we're dealing with a crisis, of course, and I think one of the challenges in West Virginia, similar to what you have described, is 1 in 20 babies born is with NAS, or Neonatal Abstinence Syndrome. But more importantly, even 1 in 6 women seem to have exposure to substances intrauterine. So we've talked a lot about both treatment as well, but we understand at a crisis level, people often say we can't jail our way out of this problem. I think we can also not exclusively treat our way out of this problem. And I think Dr. Warren's talked about the upstream aspects of this. So a lot of the information and data shows core problems as the lack of interconnectedness and social isolation leading to these social diseases of despair. Any thoughts from the panel as to what can we do from a prevention aspect in communities to actually increase the level of interconnectedness and the social cohesion that needs to happen in order to prevent not just today's crisis, but those that will happen in the next several decades? Thank you.
Great. Thank you for your question, Dr. Gupta. Any comments from Dr. Warren? Would you like to comment on that?
Sure. I think particularly, again, thinking upstream, we think about families with young children, and anybody who's had a young child or been around someone with a young child knows that parenting is not easy. And it's not just those first few weeks or first few months. It can be years. And as our colleagues who have adolescents talked about, they know this well. But parents sometimes feel like they do this work in isolation. And so thinking about what are those community supports and how do we make them aware of those? Often we find in our communities there are community supports available, but folks may be afraid to ask or they may not know they're there. And so how do we make them aware? How do we also make our clinicians and other folks that are coming into contact with kids and families aware of those services so that they can make referrals? I think the other piece particularly related to this epidemic is getting at this notion of stigma. This disorder in particular, notion of substance use disorder, there are lots of strong feelings and folks are often very ashamed, and even if help exists, may be reluctant to ask for that help. And so thinking about how we bring awareness in our communities, how we have those conversations. It's difficult, honestly, in most communities in states like Tennessee to find someone who isn't impacted in some way by substance use disorder. And so we all have that in our families and in our communities. We just need to start talking about it.
Thank you.
So I would add even one more level up. That, I think there was a book that came out a couple of years ago that was titled Nobody Bowls Alone. And you could talk about that in our communities before the ability to get in a car and drive anywhere, for before the ability to stay in your home and be on the internet and not have to go to the library to get information, we saw each other a lot more. Children were out and about on bikes a lot more, and when you're out a lot more, it's easier to support somebody in a very brief intervention when I see you. And so I think as public health practitioners, how we think about the health of a community being the health of its social structures too. And so it may not be churches or bowling alleys or the Elks Club, but what are the places where people can come together, can see each other and know that I'm not that different than you, that you have the same worries about your teenagers as you have, and that we can talk about it together and laugh. And how do we start to, as public health people, really look at communities and say, what are those common activities that could be open to everyone and that would be embracing of everyone? Because again, that's sort of if we go back to that tree picture that I showed, that's helping that community have the soil they need to be able to help each other out. And I think for any of us that have been involved in public health, you'll sometimes find that community and you'll think, wow, for some reason there's 4 or 5 normally grandmas that run this town, and they know what's going on, and they can identify, Susie's fallen off the whatever, and I'm going to grab her back and take care of her. We don't have that system in place, and I think we really have to think about what is that, and what does that feel like? How do we do that for our teenagers? How do we do that for our lonely young adults? And how do we do that in our communities that exist right now?
Great points. Dr. Patrick?
I think it has still a lot to do with isolation and social connectedness as well. I mean, the question is, what do you do about that? I think we are living in a time where it's us versus them. It doesn't matter who the us versus them is. That's where it seems like people are going to their sides. And we have to cut through that in a way that begins to unify people in whatever ways that is, through our communities of faith, through conversations, through breaking down stigma. And I think we also have to look at economic opportunity. So much of this is tied to isolation, lack of economic opportunity in many communities that have been disproportionately affected over the last 20 years by loss of jobs, manufacturing jobs. There are communities that have just still not recovered. My hometown has a pretty high unemployment rate, has a pretty high rate of neonatal abstinence syndrome too. These things are tied together. I think we do have to come back to the fact that we are our brother's keeper and we are our sister's keeper. That there's nothing more powerful than saying to somebody, you matter. And it's why we love being clinicians, right? You get to be that force in someone's life to show them that they matter, and it gives you value, they get value, and we have to come back to that connection with one another.
Great, thank you. Let's take a few questions from our online viewers.
Absolutely. If you had one takeaway point or recommendation for state health officials, what would it be?
Excellent. So, Dr. Warren, since you're in state government, I'll give that to you first. A takeaway for state health officials.
I think one is to always think as far upstream as we can and think about primary prevention, and we've talked about that. But I will add a quick second takeaway too, and that is whatever you do, make sure that it is data driven. There are lots of thoughts. People have lots of opinions on this particular topic. And for example, around neonatal abstinence syndrome, there were lots of thoughts when we started our surveillance about what these moms were using during pregnancy that were leading to neonatal abstinence syndrome. And one of the things that was most surprising to us, and we were able to verify through our data, was that 75 to 80% of our babies with neonatal abstinence syndrome were born to moms who got at least one of those prescription substances from a healthcare provider. And that really helped to start change the conversation. People will often say it's those bad moms over there who are doing those things and getting those drugs from somewhere. Well, in fact, we know where they're getting those drugs from, and they're getting them from people who look like me. And so there's an opportunity to use that data to drive that work. And so I think really having a data-driven approach is really important.
Dr. Warren, thanks for mentioning that, because I also agree with you. Part of our approach here in Massachusetts has been that part of the strategy of how to address the opioid epidemic is that data is the cornerstone of the strategy. So we all have different beliefs and we come from different places and different angles, but if you put the data out, local, current, accurate data, and then use that to drive the policy and the programming, we found that to be incredibly enlightening and effective for us again. So I appreciate that. State health officers? Okay.
Well, I think, one of the things we were talking about even earlier today was, and Dr. Gupta alluded to it as well, we have like piecemeal approaches that sort of attack one little problem, treatment, prevention. What this really requires is a comprehensive, thoughtful approach. And as you know, I'll turn to the not state health officials, but what's happening in Congress right now, both in the House and the Senate, there are a multitude of bills that address the opioid epidemic, including many that address needs of pregnant women and infants. One of the worries that I have is that we haven't had a massive investment in resources to tackle this problem, like the Ryan White Act, that is comprehensive. It builds infrastructure. It is thoughtful, and it's not siloed in one place or the other. I think that way you can begin to balance the needs of prevention, treatment, following infants to make sure that they're receiving the developmental services. All of those things. One-offs are important, but it has to be thoughtful and coordinated.
Thank you.
So
Dr. Ray?
having been a state health official,
Yes.
kind of two pragmatic things. One is always leverage what you're doing for one disease for other diseases. So that weekly report, once people are used to seeing it, we don't even know what the next epidemic will be, but to be able to have that infrastructure and have it live beyond one commissioner or one state health official, I think is really important. And then the other thing that I think is critical here that I don't know if you all are talking about is how do you communicate and test how these messages are resonating with clinicians. Because everybody always says as a clinician, those clinicians that look like you, Dr. Warren, that prescribe that drug, they probably don't know because they've never had the follow-up back to them. That did you know that, patients that you took out the wisdom teeth, and gave them all 60 days worth of hydrocodone when they really only needed 2 or 3 days worth, that's a real problem. And so how they become part of the solution, rather than not just a finger pointing, we're going to look at your prescription monitoring drug database, but I own this epidemic too, and I'm going to be part of the solution. And I think in public health and in the clinical world, it's always to go from an us and them to the we're in this battle together, and it means a lot to us for the whole state rather than just the public health community.
That's a great point, and having lived in both the public health and the medical clinical world, it's been really satisfying to me to see when we do engage and bring together, here are the PMP results, and we're going to give each individual their PMP results so that they can see what has happened in the last year. And we're always surprised as clinicians when we see what the actual data shows, and having that back and forth about what do you need to learn clinically, what are the competencies that you need, how can we be helpful in that training. I think that's a great point.
And to also celebrate the successes with them.
Sure.
So that they feel like, if we're having less babies that are needing to be in the NICU, I was part of that, because I'm using less narcotics, or I'm identifying it earlier and asking those questions and getting those people treatment.
And I think to that,
one of the key things that I think Dr. Rimley mentioned, it was this notion of engagement. And so, we talk about guidelines for providers. Public health really needs to make sure that we pull in those providers, have them actively engaged in that conversation. There's this sort of maximum we talk about, nothing about us without us. And so we talk about engaging communities in that way, whether that community is a community of prescribers and clinicians, or whether that's a city or a county and we're trying to think about an intervention, really focusing on that engagement.
that's a great point. Thank you. Let's take another question from our online viewers.
Speaking of engagement, how do we help parents work through the other stressors and issues such as strained relationships or food insecurity or other issues that often co-occur with substance misuse and addiction?
Dr. Remley, do you want to take that? You talked a little bit about the social determinants.
I think for a lot of that, it's, again, I think we've all talked about it in a different way, but how do we make sure that every parent, whatever that parenting group is, whether it's a mom by herself or with a husband or with a spouse or with a partner or with a grandparent or the next door neighbor, that we make sure before they leave that hospital with a baby, they have those right resources. So I think it's making sure before they leave the nursery, we're asking those questions. And then as that baby goes to wherever they go for their follow-up, and this is where it gets harder all the time, because frequently who sees you in the hospital when your baby's born is not who you see at your 2-week checkup. And then you might see somebody different at your 4-month checkup. And so how we bring in home visitation and how we kind of have those wraparound services, and that starts with policy. It starts with the country saying our most precious resource is our children, and we want to have wraparound services for every child and every family, and to assume that everybody needs that help and support so there's no stigma attached with it, and that you can say, no thank you, I don't need it, rather than, do you need extra help? And so I think if we can start to change that conversation, so every family, when they have a child and are going home, gets asked those questions in a very common sense way to be able to get the support they need. I don't know, you do that every day, so Stephen?
Yeah, that's right.
Yeah.
I think it is beginning to structure to universally assess these things to where it doesn't build in bias in your assessments and you just assume that everyone needs to be asked those series of questions and connected to those services. We know 1 in 6 kids are food insecure. I mean, it's not an uncommon problem. So that sort of warm handoff, and to make sure that we have WIC forms. It's something we do. We ask every family, like, do you need, connection to WIC? Those are things that need to be structured, we need to think about. And I think we do need to enhance those particular home nurse visitation, other things like that can assess the family outside. We have a sick care system, right? Where I can order, $10,000 worth of tests in the ICU tomorrow, but I have a hard time getting physical therapy for a baby when they go home. And this is one of the issues that needs to be addressed so that we can shift the resources where they actually are needed. You save 1 day of a hospitalization, you can fund a lot for an infant when they go home.
Dr. Warren?
Yeah, I would just add, I think making sure that our clinical partners have the information. A lot of times there are programs that are available, and there are certainly opportunities to fill in gaps, but where we do have programs available, making sure that our clinical partners know what those are and how to refer. It can be really daunting, having been a primary care pediatrician before this, when you're seeing a family for 15 or 20 minutes and trying to then think about, well, in this particular community, for this family with these eligibility criteria, what home visiting programs might exist and how might I refer them there? And so thinking about making sure we know those programs are available as clinicians, and then we make them as easy to access as possible.
It's a great point. And, as I think about, Dr. Remley spoke earlier about multiple eyes from a community, what everybody's saying is kind of getting at that too, whether it's our Moms Do Care program or home nurse visitation, which we haven't talked much about yet up until now, or somebody coming into the WIC center or coming in to get early intervention. It's multiple people coming around the person in a hopefully coordinated way. For my colleagues in state health, I think it's also helpful to think about what levers you can push that make some of these automatic. So the piece that Dr. Warren is talking about, or Dr. Patrick, about thinking about that or knowing the resources are not as much of an issue. So for example, in Massachusetts, a diagnosis of neonatal abstinence syndrome is an automatic referral to early intervention for the first year of life. So that just helps to alleviate some of the stress on the clinicians of having to think through that stuff. So there's other levers like that we can make more automatic that are also worth thinking about. Let's take some questions if you have any, or comments from our wonderful audience here on this beautiful Friday afternoon. Any questions from the audience? Comments?
I have a question.
Please.
Miranda Daniloff-Mancusi. I think I would know this by now. Miranda Daniloff-Mancusi, I'm on staff here at the Harvard School of Public Health, and I would really love just to hear an overview of what some of the problems are with some of these kids that are born this way. I mean, what happens? What are some of the issues?
Great question.
So I'll start. There was a long-term study done in Australia that looked at the outcomes of children 4 and 8 years out. We know they are 3 times more likely to have anxiety disorders. They are 4 times more likely to have behavioral health problems. But what we don't know, and it's hard when you look at this data, is we don't have a randomized controlled study to look at children that were in the same adverse childhood experiences without neonatal abstinence syndrome. So that's good information for us to look at, because what we can't tell is if Stephen had a child that had 5 adverse childhood experiences and I had one that 5 adverse childhood experiences and was exposed to neonatal abstinence syndrome, do they end up in the same place, or is this another additional factor? So I think we think it probably is, but I think it's important for us to do the research to follow these kids longer than when they leave the NICU, because there's a lot of misconceptions out there. So, anybody here who's been a mother or a father, if you take your child to preschool and they say they can't sit still and they don't behave, you say, oh, that's because I used drugs back when I was pregnant. And that may not be true at all. But we put, again, it's that stigma and that label we're putting on these kids. I think we know we want to identify they need early intervention because we want to prevent those behavioral problems or those anxiety problems. We want to improve the environment they're in, because we do know with children in adverse childhood experiences, if we can change those in early childhood, we can change the trajectory of those kids. But we don't have enough long-term studies yet. I think there's one, NIH is just starting, right, last year, that's going to look at these children long-term.
I would echo that. I also think that we have to be mindful that we've been down this path before. In the 80s, we had Time magazine that had a lost generation of crack babies. And we found that not to be true in long-term studies, and all that really did was serve to stigmatize both moms and infants, and I think we need to be cautious about that. The literature that we do have from 70s, 80s to now suggests, at least my look at it, is that first off, just like you alluded to, there's multiple potential sources of confounding. One is the environment, the other is other exposures like alcohol, and we talk a lot about opioids, but there are 1 in 10 pregnant women still use alcohol. Tobacco use is increasingly common, and we know from some of our work that it's not generally one substance, it's usually multiple substances that are used. And so our goal really does need to be healthy moms and babies. But in these long-term studies, it's really hard to disentangle what's going on because of that level of confounding. The literature overall suggests that there may be some issues with attention, maybe some visual issues with like lazy eye, maybe some IQ points, but my read of it, at least at its current state, is mostly reassuring that these issues don't result in massive long-term problems. But we really do need more data, more studies to really follow a large cohort of infants to really understand what's happening in school age so that we can intervene, so that we can provide additional resources for children. It's incredibly important.
Thank you.
And I would also add, I think it's really important for us not to get solely focused on a diagnosis of neonatal abstinence syndrome. So as Dr. Patrick can describe much more eloquently than I, there's a lot of variability. And so we know that 2 women with the same exposures or similar exposures might have babies with very different outcomes. You might have one with NAS, one without NAS. And it's not the NAS per se that creates the risk, right? We think about that context, that environment. Those environments may be very similar, but if we just focus on the babies with NAS and we don't ask those broader questions about risk, and as the other panelists have said, take a universal approach to screening and ask those questions of everybody, we're going to miss some of those babies. So actually the babies I worry about the most are the ones where there is exposure, but they don't develop an NAS, because in many cases those then don't end up on someone's radar, and those services aren't necessarily connected with those families, and yet the risk is still there.
I just had one last point, and that's how much does our postnatal treatment also affect development? What is the effect of separating the mom from the infant? What is the effect of a 90-day hospitalization in some cases? Drug withdrawal doesn't last 90 days in adults. And so it really is something to think about, why infants stay in the hospital so long. We had a study that came out a few weeks ago in the Journal of Pediatrics that looked at infants that were discharged home on medications. We found in that study that infants that went home on medications were on medications for 3 times longer than those treated inpatient. And the infant that stayed on the longest was on a medication for 200 days. And what's even more disturbing about that is that the medication that was most commonly used in this study was phenobarbital. And we know from some studies, there's a nice randomized controlled trial from the early 90s in New England Journal looking at febrile seizures treatment with phenobarbital that found some issues with development with phenobarbital. And it's a medication for neonatal seizures we're starting not to use, but it's still used for neonatal abstinence syndrome. So I think we need to be thoughtful about how we can optimize outcomes post-discharge and in the hospital.
Really good point. I think we have time for one last question. Is there an online question?
There is. Could all the panelists share how their states have reduced the very real barrier or threat that pregnant women face when coming forward about using drugs during pregnancy and being reported to Child Protective Services?
Does anyone
No one's
talk
jumping
about
at that
that?
one. Yeah. So I think we have a long way to go, and it's not just within one state; it's multiple states. Tennessee had a law on the books that a woman who used an illegal substance could be arrested and charged with a misdemeanor for 2 years. And it really was the work of people like Dr. Warren and the Tennessee Department of Health and other folks to educate people why this was bad for moms and babies, to really fight through that stigma to protect moms and babies. I still think we have a long way to go. We haven't really even touched upon many of the child welfare issues. There are multiple changes being considered right now by the federal government, essentially trying to create plans of safe care that include the needs of the mom, including connecting her to treatment. In my experience, that's not happening in many states right now. It's not in one state in particular, and I'm hopeful that Congress is beginning to address this problem. There's a bill currently now that provides additional funding to states to create plans of safe care and provides some guidance to states on how to do that. What's happened over the last few years is states are basically said, you need to refer every infant that has drug withdrawal, regardless of the source, even if they are, a mom is on opioid agonist therapy, and create a plan of safe care. But they weren't giving guidance, they weren't giving money, and all that it's resulted in many cases just reporting to child welfare. So we really need to do more work.
So from an academy perspective, we work with every state to look at their laws and see what they can do. But the bottom line is, from the academy's perspective, mothers and children belong together. They shouldn't be separated at the border. They shouldn't be separated in hospitals. Whenever a mother can take care of her child, and the doctor and the mothers work together on what is the safest opportunity to care for them, families belong together. So that's the message we give, and in each state it's a little bit different effort to look at laws and figure out how we can help advocate for doing that. But I think what's important for us to think about is it is broader than just opioid use. It is families belong together. The Families First Act, I don't know about you all, but I went to sleep one night and woke up and went, oh my gosh, there was bipartisan legislation that is good for children and families. And I was like, pinch me, it couldn't have, I was just surprised it happened, but that will help us help keep families together. And I think that should be the big overarching theme here, is whether it's from opioid addiction or whether it's from mothers who are in prison or mothers who are separated from their children at the border. We need to keep families together. That's the worst adverse childhood experience, is to not be with your parent.
Great point. Thank you. Well, we've covered an unbelievable amount of ground here, and I'm sure you were all equally inspired by our incredibly knowledgeable panelists who are doing just exceptional work in this area. We've talked about prevention, primary prevention, the bread and butter of the work that we do. We've talked about prevention in the form of education, both for community members and clinicians, and we've talked about the role of state agencies, including health agencies, in drafting guidelines and policies and making things easier to do and being the source of information and having web-based information accessible to all. We've talked about treatment and how to make treatment more accessible and how to help and support women and dads who are in recovery. And I think it's really helped us think through not only in the sick care system, but in the health care system, how we can think through this. There's obviously a lot of work to be done in this area, but you've heard so much about these real shining examples of things that we can look to in all of our work, and I really appreciate that. I want to give the panelists one final chance for a take-home message that you'd like for the audience. Dr. Patrick, I'll start with you.
Well, I think we do need to continue to change the frame that addiction is a chronic relapsing medical condition that requires treatment, and that needs to be what drives the decisions that we make. I also think that we need a comprehensive, thoughtful approach that requires a substantial amount of investment by both the federal government and states to improve this. We are still seeing escalating rates of overdose death, increasingly maternal mortality, just as you described, and other states are reporting this too, is attributed to overdose death, increasing rates of neonatal abstinence syndrome. The time to act is now. It was actually a few years ago. I think it's time to get on it, and we need a massive investment to do that, and we need it yesterday.
Thank you. Dr. Remley?
So I would say, as we look at everything that's happening in our society, investing in counselors and more support in middle and high school, to be able to have more trusted parents and people that children and young adults can go to, so that there's less of this sense of isolation. And for people who are at high risk of addiction, they have somewhere to go early on to prevent that from happening. I think that, coupled with, I think Dr. Warren talked a lot about having the clinical community understand the role they can play and how important it is to be able to. I come from a time where, I practiced long before pain was a fifth vital sign. And, there were many times where I would stitch up a child in the ER and say to the mom, we're going to give them a little bit of numbing medicine. They're going to cry, but in 20 minutes they'll be ready to go home and eat dinner and they'll be happy. That same child, for a long period of time over the last 10 years, would get large amounts of conscious sedation. So resetting in the clinical community, what is pain? What are all the different ways we can talk about pain, and how can we take care of it? I think will go a long ways to to also preventing that group of people who are at a high likelihood of being addicted to not be addicted.
Thank you. Dr. Warren?
A couple of parting thoughts. I think one, we always think about primary prevention. Certainly in the short term, there is an absolute need for treatment, and we say a need for more treatment. And so we hope that over time that balance will shift and we will need less of that treatment because we've really focused on primary prevention. But it's not a one or the other. It's a both and right now. And then the final thing I would say is we're all in this together. Public health does this very well. We convene partners. It's not just about community organizations or clinicians. It's also about patients and community members. And so thinking about how we remember to put those folks first and understand those perspectives really to help drive our work.
Thank you, Dr. Warren. And you know, I'll end where we started. We're in the middle of an epidemic right now. With everything that we've spoken about and all the grim statistics that we shared, you know, I remain hopeful and encouraged. As I mentioned when we first started, I spent a long time trying to help individuals with substance use disorder, this medical disease. And I've never before in Massachusetts and across the country seen so much energy and real commitment to do something about this medical disease and finally give people the treatment and recovery options they deserve. So I really think if we continue to band together like this, we will finally make progress in this really devastating medical disease. Once again, thank you to our wonderful panelists. It was such a pleasure to be with you here today, and thank you all for being here.